Okay, can I go ahead? I believe it is live.
1 second, sir.
Yes.
Yes, sir, we can start.
Very good evening, everybody. Very good evening to the professors who joined, the speakers, eminent speakers, as well as who is the doctors on the call. Pfizer Rare Diseases welcomes you all for this wonderful, academic session today evening. We are blessed, Pfizer is really, blessed to have two great academicians at one go. So, it is our fortune to have Dr. Sriram Mahadevan, the professor and HOD for Sri Ramchandra Medical College at Chennai, Tamil Nadu. At least, the endocrine fraternity and many number of doctors don't require any introduction about Dr. Sriram. So, very eminent endocrinologist, passed out of PGI for his general medicine as well as the DM endocrinology. To the core, a great clinician and teacher with many papers and many chapters to the textbooks. So, and his continued research in diabetes and core endocrinology. Many forums, he is the eminent speaker also. There is no need to name n number of endocrine meetings. Sir is the speaker, and he was the honorary national professor also by the Indian Medical Association, from 2015. So to the core clinician, academician, and teacher. So 100% we will be able to bask in the wisdom of Dr. Sriram today evening. And and we are blessed to have always updated with his thought process, and always in the process of bringing out many endocrine students. So Dr. Praveen VP from Amrita Institute of Amrita Institute of Medical Sciences, Cochin. Sir is the clinical professor in endocrinology, and a passed out from one more PGI, SGPGI, from Lucknow, and many students were trained under sir. That is one really a value addition where one can take a lot of inputs from Praveen sir's talk. His interest in growth, growth and development, along with other aspects of endocrinology. Many publications, many publications. So national and international. And sir is the author for textbook chapters of ESA textbook of endocrinology from 2015. And he is the reviewer for IJEM also. So many DIAS, he is the national speaker. So maybe even last few days update learning also we can have from Dr. Praveen. That kind of advantage today evening we are having with both eminent speakers from both Tamil Nadu and Kerala. So personally speaking, I am associated with them for last 1.5 decade. I am blessed to have both of them on the dais. So sir, all yours. So Praveen sir and Sriram sir, we will go ahead with the proceedings. Sir, can we start with the Sriram sir's presentation? Am I correct? So Velu, sir's talk on first one is.
Yeah.
Yes, sir. Yes, sir. So thank you, sir. Thank you to have you. Today evening, Sriram. Thank you.
Good evening, everybody, and thank you, Mr. Srinivas, and everybody from the Pfizer team, Mr. Vel Murugan and others, for this wonderful opportunity. And with the permission of my colleague, Dr. Praveen, I'll start my small talk on The topic given to me by the sponsor today is on Turner syndrome and focusing on growth aspects. So I'll share my slide, and it's a pretty long talk, but I'll shorten it, and I think I'm given 20 minutes. I think I'll try to finish slightly fast. We can have some time for discussions. Yeah, I hope the slides are visible and it's moving.
Yes, sir.
Yes, sir.
Thank you, and thanks to the Pfizer team again. Too many headings under which we are given the slides deck today. I'll touch upon some of this, and mainly emphasizing on the regional and Indian aspects of challenges in the management of Turner syndrome, which is not at all a rare condition. Technically speaking, the apostrophe is not used usually. Turner's syndrome, we call only Turner syndrome. And I will try to touch upon the growth aspects and diagnostic aspects of this. As we know, Turner syndrome, Down syndrome, and a couple of other chromosomal anomalies are the commonest chromosomal disorders. And in endocrinology, we deal with not only in endocrinology, the gynecology colleagues who may also be probably listening to this, uh, is one of the commonest conditions where a serious chromosomal anomaly yields a live, alive child, and we diagnose Turner syndrome anywhere from prenatal ultrasound findings to even in late adulthood. So it's a big spectrum of presentation. And as we all understand, this is due to an anomaly in the X chromosome, one copy, and leading to multiple defects based on uh, the kind of chromosomal derangement which happens in the one of the X chromosome. And one of the main reasons for which Turner syndrome is diagnosed, suspected, either by pediatrician or by gynecologist or mainly and referred to endocrinologist, is either stature problem in a girl or primary amenorrhea, which is delayed development of sexual characteristics. These two are the most important symptoms, but however, other features are touched upon here. So prevalence of Turner syndrome are difficult to obtain in our setting, especially large epidemiological studies are quite unlikely to be done. But we get some information on the probable prevalence of these kind of conditions by either a single center big data of children coming with statural problems or amenorrhea problems, or from the karyotyping centers where we get the data on X chromosome anomalies referred as suspected Turner syndrome. And one such information, couple of studies are presented here. This is one of the big lab based information in one of the Indian journals, where out of 900 odd samples of suspected Turner, you can imagine that there's a big information of the karyotypic abnormality. So almost half of them, or slightly less than half, had confirmed Turner syndrome. Uh, the semantics I won't go into. The American College of Genetics and others have their own way of. There are certain chromosomal anomalies which may or may not come under this, especially the mosaicism. But in general, any anomaly in the X chromosome with phenotypic abnormalities which are commensurate with some forme fruste of the phenotypic manifestations of Turner, for all clinical purposes, should be classified under Turner syndrome. So, for example, you will have odd variants where Y chromosome may be present along with it, and which will have serious connotation. And you can have a mosaicism where there will be a 45XO and a 46 XX or XY, in which case the disorders of sexual differentiation kind of presentations, mixed gonadal dysgenesis, all these will overlap with a classic Turner. But for all practical purpose for today's discussion, we will take only the classic Turner where there is a 45XO kind of a presentation, which is what we'll discuss today. So with this in the background, and unlike all other genetic anomalies, here it is a clear-cut chromosomal abnormality which can be picked up by karyotyping. It has serious phenotypic presentations. And quite a few studies have been done on the correlation between the external phenotypic manifestations versus the different genotypic anomalies seen in Turner syndrome. And main phenotype is short stature, which happens in Turner mainly because of the absence of the SHOX gene in the X chromosome. And the uh, development of ovary is directly affected because of the deletion of the long arm of the X chromosome. And you can have multiple other anomalies due to various uh, defects in this sex chromosome. And as we all know, this is being repeatedly emphasized to our pediatric undergraduate postings also, as well as in post graduation. How all we suspect, as I already mentioned, more than 80-90% of Turner syndrome, especially in our setting, are even today picked up very late after the age of 13 and 15, when the mother brings the child for not having pubertal development in the normal way. This is unfortunately, we have missed the bus by almost a decade. Ideally, we should pick up patients in short stature. Retrospectively, in every patient, we get this history of the child not growing well from the early childhood. But I think the listeners who are practicing pediatricians and OGs will definitely understand that we should ideally pick up the child between the age of 6 to 8 at least, if not before 6, when the child presents with short stature. That should be the aim of diagnosis early. However, more often we get late. Similarly, neonatologists are very well aware that there could be a child born, a newborn neonate having lymphedema, either in the extremities or in the neck, a cystic hygroma kind of presentation, etc., can be a clue for a serious underlying chromosomal anomaly. And these can be sometimes picked up even in the antenatal ultrasound done in the 5th month for anomalies. Other rarer, less common, more often missed kind of presentations or ENT presentations, recurrent otitis media and hearing defects. And fortunately, this Turner, even though they have serious congenital cardiac problems, in the sense a typical bicuspid aortic valve is the most common, or they can have even coarctation and other aortic root anomalies. But these presentations as the primary manifestation of Turner is quite unlikely in a given patient. Subtle skeletal anomalies are repeatedly discussed in a typical bedside discussion, either in an endocrine postgraduate teaching or in pediatrics. Worth remembering and carefully we have to look into. These are all subtle clues for the various uh, anomalies at the musculoskeletal level, which happens not uncommonly in Turner. The importance of enumerating all this and knowing this is to pick up these things when a child is walking in. And this also tells us about the, yeah, mild skeletal dysplasia kind of the overall phenotypic expression of this condition. The implication of knowing this in this conceptual manner is that because there is a skeletal anomaly, which is, as you can see, a lot of these things are mentioned here, response to growth hormone is also slightly or much less than what we expect. So this is a kind of a skeletal dysplasia, a skeletal resistance kind of a condition where you require higher doses of the growth promoting therapies to increase the height of a child with classic Turner syndrome. Not only that these children have short stature and primary ovarian failure as the cause of endocrine presentation, there are other autoimmune diseases which they are prone to, especially from the thyroid and pancreatic beta cell function point of view. They are prone for more chances of type 1 diabetes and autoimmune thyroid disease. So these also have to be kept in mind. So in addition to all these physical abnormalities, a child can have problems in learning. So, performance in the school, difficulty in processing complex tasks, or some of the other anomalies which you can pick up if you do detailed testing on these kind of children. But more often, these are all not the presenting manifestations. Any child who is not doing well at school, you won't be checking all this. But coupled with all the other musculoskeletal phenotypic abnormalities, you might be able to pick up a child with these problems. So, investigation and diagnosis, as I mentioned already, a typical Indian child, especially from a second tier town, etc., are more often coming to us only with primary ovarian dysfunction, presenting as either primary amenorrhea most commonly or secondary amenorrhea. However, retrospectively, they will have all other things which I already mentioned. So repeatedly, this is what we learn, but a day should come in the near future when we should pick up by routinely monitoring their growth. And any short girl before the age of 8, if at all you suspect that something is abnormal, pathological short stature is suspected, should definitely be investigated for Turner. So one very important take home point of all these discussions with respect to short stature, any short girl after the routine investigations should be investigated for Turner. Always keep Turner in the possibility of a child with girl with short stature, girl with primary amenorrhea. So karyotypic abnormalities, I think these details are in the evening of a presentation like this. Let us spend less time on the intricacies of karyotyping. Please remember that we need to at least do 25 cells properly and send it to labs which do it routinely. There are many occasions where we have had spurious reports. Use fish if you are in doubt, which the report comes much earlier. But the complete karyotyping of at least 25, preferably 50 cells is required to rule out mosaicism. But just to diagnose Turner, if suspected, with even a couple of cells, 45X is always diagnostic, if not all cells. So I wouldn't go much into the prenatal diagnosis, but you can suspect today both by a good anomaly scan done at the 5th month and they can pick up the, as I already mentioned, the lymphedema part. They can pick up cardiac anomalies and a good astute observation renal anomalies. So all these are clues for the child having problems. And as early as 9 to 11 weeks, you can pick up increased nuchal translucency and cystic hygroma, which I already mentioned. And these are all clues. Unfortunately, many of these abnormalities may not be present, and Turner will present very subtle way, and we miss it very often in the early features. But worth remembering all this in an academic presentation like this, so that we have our index of suspicion quite low in a given, the threshold should be low for investigating these patients. So how do we diagnose? The confirmation is only by karyotyping, and fish and other analysis are, to be used judiciously based on your setup. Clinical suspicion is paramount. All other things will fall into place once you suspect it clinically. Then comes today's more focused discussion on the growth hormone use in Turner condition. And we know that growth hormone deficiency is one of the important indications where there's an excellent response, but any other non-growth hormone deficiency indication of short stature this is one of the FDA approved indications, one of the earliest, in fact, to get approved. And a short child with Turner syndrome is a definite indication. And the safety of this therapy has been now well proven for more than almost 3 decades now in the usage of growth hormone in this condition. So some predictive factors, as always in endocrinology, in clinical endocrinology, you have a taller parent, you start the treatment very early, and you use a good dose, definitely the outcome is going to be better. And you delay the puberty slightly accordingly. Obviously, that child will respond to a given therapy better. But please remember, as I mentioned already, that because the Turner condition has a lot of skeletal issues, your response to growth hormone, even though we are going to discuss the doses, may not be at the same level as we expect in a growth hormone deficiency child, or for that matter, even in some of the idiopathic short stature conditions. And repeatedly these things will be mentioned, that this is an indication of growth hormone therapy where the child is not having any growth hormone IGF-1 axis problem. It is not a deficiency. In fact, as I repeatedly mentioning, it may be a slight resistance state. So we have to use a stiff dose of growth hormone. And so the monitoring is not only oxological, and very importantly, whenever you use supraphysiological or higher doses of growth hormone, we need to monitor insulin-like growth factor 1 to keep the levels of IGF-1 at an acceptable level without causing the metabolic side effects, mainly diabetes and dyslipidemia and dysglycemia in these conditions. So these are all the effects which we need to remember, and some of the other rarer side effects of growth hormone therapy. So please remember that you need not do an elaborate growth hormone axis stimulation or any test to start growth hormone therapy in a Turner syndrome patient. So unlike other causes of short stature, non-growth hormone deficiency conditions you do not need. So growth hormone in CKD, growth hormone in Turner, growth hormone in Noonan, growth hormone in Prader-Willi, all these kind of indications of growth hormone therapy do not require elaborate testing of growth hormone. You have to only document that the child is falling short over a period of 6 months or maybe rarely 1 year for the average expected for that family. If the child is well below that limit in the growth chart, you start growth hormone. So best or ideal will be to start a Turner patient when the child is coming for some evaluation of short stature between the age of 6 to 8. I would like to share here, maybe Dr. Praveen can later add more. In this almost now 20 years of our practice in Chennai, I have been fortunate to diagnose Turner at the age of 6 to 8 only in 3 or 4 patients. And most often we diagnose after the age of 12. And it's unfortunate. And that time also we give some leverage to the patient. We discuss with the parents in great detail and start growth hormone for at least 1 or 2 years, delay the puberty by 1.5 to 2 years. So it needs a lot of discussion, because the primary aim will be, the reproductive issues, not not the stature at that given point of time. So these are all socio-cultural aspects of problems we face in the therapy of growth hormone in Turner in our setting. This GH deficiency thing, I don't think I need to elaborate here. You have multiple reasons. Response is excellent, except in very rare situations. So in any condition where we use growth hormone, which is otherwise in Indian setup, where the patients are paying out of their, savings and from their pocket, we need to know that the optimum duration, optimum dose should be given so that you achieve a maximum height outcome in a given setting. So from that perspective, you see that the growth hormone therapy in a deficiency child will be anywhere from 0.2 to 0.4 milligram per kg per week. It will be almost 1.5 to 2 times in a Turner syndrome child. So these are all slides which are explaining the probable rarer side effects of growth hormone. Fortunately, we don't see it that frequently, but in a given patient, it can happen, so that we monitor for these rarer things, including benign intracranial hypertension. Any child with scoliosis, be very careful. The tethering of cord in disproportionate growth of the spine could be a serious issue. Slipped capital femoral epiphysis, etc., or rarely edema, severe edema, peripheral edema. These are all in neuropathy. These are all some rarer side effects. And growth hormone therapy would unmask an underlying hypothyroidism or even adrenal insufficiency, which we need to remember. And anything, if at all specific for Turner syndrome, as I mentioned previously, the Turner children are already, the girls are prone for autoimmune conditions. And it may happen that you start growth hormone and it coincides with the unmasking of the autoimmune condition. Beware of that. And if your response is not good, always rule out hypothyroidism. So the next couple of minutes on reassuring studies of growth hormone therapy in Turner syndrome. There are some real world experiences, quite a few of them. The crux or the bottom line of all these studies that you start early, you treat them adequately at the good dose tolerated by the child, your outcome is going to be quite good. What is that usual outcome we all think of? A child crossing 145 to anything above 140 itself is good, but anything around 150 is amazing in a growth hormone, in a Turner child. So 5 feet in Indian setup, when the average Indian girl, especially South Indian women itself is low, will be too good response. And if that is achieved, is a superb outcome. And you can see one of the studies from Hyderabad. Dr. Danda, Sridevi, and others have published quite a few years back in our IJEM journal, and the height outcome was quite reasonably reassuring in that study. So this is again another study to tell us that the SHOX gene mutation in Turner syndrome is the primary cause we know, and growth hormone therapy resulted in quite a good response in these children. Then the question comes, is it should be always growth hormone? Is there not other ways of improving the height in a Turner? People have tried a couple of them, which are mentioned for completion's sake. One is oxandrolone therapy, a non-aromatizable androgen therapy, which is an analog of androgen. Unfortunately, not available in our setup, and we read repeatedly in our academic forum that this is quite useful. And the current Cincinnati guidelines of 2017 also mentions about the use of oxandrolone either with or without growth hormone. So growth hormone with oxandrolone can also be tried, especially in a child which has been started quite late. So if available in our setup, probably these children will have good benefits from oxandrolone therapy. Similarly, the concept of estrogen therapy in a pre-pubertal, anyway in Turner syndrome, we are going to use estrogen to induce puberty at the appropriate age, usually around 12 to 13 years of age or 12 to 13 plus. However, what is the dose of estrogen used here is pretty low. The concept here is that even in a pre-pubertal girl, the ovary secretes very small amounts of estrogen to the tune of around nanograms, and that will have a favorable effect on the skeletal growth. And this has been taken to advantage, and there are studies which are published quite a few years back on the usage of such low doses of growth, the estrogen, ethinyl estradiol in a child with diagnosed Turner and improving the height. All these are quite promising, but many of these are not available at these doses in our setup, and I think the Indian experience will be almost negligible with this. And these are all extremes of desperate ways of improving height, and more often we don't use it in Turner syndrome. These are all limb lengthening procedures, which are more often used in achondroplasia and those kind of serious skeletal dysplasia conditions. And growth hormone in Turner syndrome, I have mentioned that the summary of some of these slides which are repeatedly mentioning is that it's quite safe. Use it at the appropriate dose. The dose will be relatively higher than a growth hormone deficiency patient. And monitor for side effects. If you do this, your outcome is bound to be good. And we all know the CABI International Growth Study KIGS group, which are monitoring and taking data of growth hormone usage in a spectrum of conditions. And the standard results we learn repeatedly from such big post-marketing kind of data is that you start early, it is better. and use the right doses. Education of the patient is important in our setup. Storage, where they are using, whether they are using it continuously, etc., are also important. This is interesting that in Japan they tried a lower dose of growth hormone in Turner syndrome with some reasonable effects. I would rather take it with a pinch of salt. These kind of presentations, they are Japanese are usually on the shorter side already, and achieving a height in that population may not be at a lower dose might have been possible for various other reasons beyond growth hormone. So from the guideline point of view, I would like to only mention the growth hormone aspects. I am not going to discuss how to monitor for metabolic effects, autoimmune conditions, cardiac, neurological, psychological, reproductive. All these things have to be taken into consideration in the long run as a child grows and enters adulthood. So I'll just mention the Cincinnati guidelines, which are the most often quoted in Turner syndrome condition and the various facets of therapy and management of Turner. In that, the growth aspects alone I'll mention in the next couple of minutes and I'll end my talk there. So here it has been clearly mentioned that ideally we should start growth hormone at the age of 4 to 6 in a Turner, which is not going to happen that easily. So whenever you start, give at least for 1 to 2 years. That is my small take here, and I hope our other colleagues who are listening and my colleague Praveen and others can add to this. We give at least an year's time. This is definitely true for growth hormone deficiency, but in Turner also, even if a child comes to us at the age of 12 or 13, we talk to them, we give for at least 1 or 2 years of growth hormone and then only induce puberty. And these are all some of the standard indications and what all to expect. You start as early as possible and don't waste time in testing too much of the growth hormone dynamics. IGF-1 is good enough. A baseline is required because you need to monitor IGF-1 when you are treating the child over the next 6 months. And you see the doses here, which is much higher than you, somewhere around 15 to 20 or maybe up to 30, 35 is the microgram per kg is the dose for growth hormone deficiency. You see here in Turner, we start with 45 to 50. And you may have to go even up to 60 or 70 rarely. But when I say all this in an academic forum like this, please remember the cost will go enormously high in a given Indian setup. And I really wish the cost of therapy in those children who are desperate to grow, and you have to use growth hormone, brands accordingly. And what do you monitor in all growth hormone treated patients? Obviously, for statural purpose, stature is the first you will monitor, and use appropriate wall-mounted height scales which are reliable so that you have a reasonable account of what's happening in that patient at least once in every 4 to 6 months, and monitor biochemically for IGF-1. Safety is important. In contrast to growth hormone deficiency, where the response will be excellent, and a standard Indian bedside teaching is that in a growth hormone deficiency child, if the response is very good, you don't even need to do IGF-1 monitoring. But here I cannot say that. You need to do IGF-1 because here we are giving it in a non-statural, non-growth hormone deficiency indication, and the response is going to be varied, and we don't want the unnecessary adverse effects of excessive growth hormone in a given child, especially on lipids and other, glucose, blood pressure, and other metabolic effects. And the outcome which is reasonably suspected, as you can see, the evidence is not too strong here, is that even if 1 standard deviation or 2 standard deviation the child goes from the baseline, it's good enough. And let us not have too big an expectation, and you continue growth hormone as much as possible in that patient as the patient can afford and based on the response. These are all some practical things we face in our setup. I already mentioned that the typical Cincinnati and other Western guidelines will definitely mention about oxandrolone as well as very low dose estrogen, etc. But this is in our setup, a therapy which is usually not given for unavailability of the same. And we usually continue therapy, even though it is usually written 11 to 12 years, and we may have to induce puberty accordingly. we definitely delay. I can share with you that personally, in many of our patients, we give therapy even up to 15 years. Even 15 plus, we have started induced puberty very late in our Turner patients after full discussion with the patient. So in patients with kyphoscoliosis, be more careful and use your social and other cultural assessment before embarking on induction of puberty in a given patient. So I think that is one of my last slides, and thanks to the makers of Genotropin Pfizer today for one more opportunity to discuss one aspect of growth hormone therapy in important genetic condition like Turner syndrome. Thank you very much, and I think the questions are anything we'll discuss. Thank you again.
Sir, glad to hear from you, Sriram sir. So wonderful. So, sir, questions. Few questions are there. Maybe post presentation of Dr. Praveen. We will take up all the questions at one go with your permission, Sriram sir. So, sir, I'm okay with it, sir. Can I go ahead, sir?
Yeah, please.
Yes, sir. Praveen sir, please, you can go ahead with your presentation, sir.
All right.
Yes.
Good evening, everyone. Can you see my slides?
Yes, sir. It is perfectly visible. Perfectly visible, sir. You can just go to slide mode, screen mode, sir.
All right. So I'd like to begin by thanking the audience and also Mr. Srinivas and the rest of the Pfizer team for this opportunity. And it's pretty late, so I'll try to make short work of my presentation, and it deals with the latest guidelines on growth hormone use and other aspects in growth hormone deficiency and idiopathic short stature. And this is the disclaimer slide. And I've taken the liberty of adding a number of slides of my own making. And this is outline of the talk. I'll just discuss the changing landscape of growth disorders, a bit in detail about idiopathic short stature and the use of growth hormone. So basically, it was just description of short stature prior to mid 20th century. The whole world of short stature evaluation opened up with the discovery of all those wonderful hormonal assays and the biochemistry. So things really picked up by 80s, and because something which could be studied very nicely, the growth hormone axis was supposed to be of paramount importance. In fact, most of the things revolved around growth hormone axis, especially because growth hormone therapy was something which was discovered as early as late 1970s. Later on, with the access to massive parallel sequencing, processing, and all those genetic techniques, we slowly understood that growth hormone deficiency is just a small portion of the whole spectrum of short stature. And mostly it's about the growth plate disorders. And there are a number of pathways which are involved in this aspect, and we will discuss it shortly. But it remains to be said that our therapeutic options are still very limited, and the major one is still growth hormone. All the other options are used in some very specialized and specific clinical situations. Abnormal growth is something which I'm not going to elaborate on for this audience. So basically our thoughts or our evaluation centers on trying to find out the etiological aspect. And the first question probably is whether it's just a transient slowing indicating constitution delay. Is there a disease or a deficiency state or an excess? Is there a genetic problem? Is it a small for gestational age situation? Or sometimes it may be that there are no clinical clues or biochemical, hormonal, or chromosomal clues. Then we call it as idiopathic short stature. Again, we have all these wonderfully developed growth charts, and we have even the extended growth charts in use now. And we have the latest formulas for estimation of the target height. So all these things are in place. So it's about carefully charting out and plotting the growth curve. So the most important thing is to have a clear idea about the disorders themselves. So the most important and the practical aspect of the classification, personally, I believe it to be from the International Classification of Pediatric Diagnosis. As you can see, it is endorsed by most of the pediatric endocrine societies. So according to this society, and this was published way back in 2015, the center analysis of growth disorders should be based on growth plates. And if you have a disorder which is primarily affecting the growth plate, then it's called a primary growth failure. Most of the clinically defined syndromes fall in this category. Skeletal dysplasias, of course, it's well evident. And SGA, or small for gestational age, especially when there are no other factors which are discovered, they are thought to fit in with a primary growth failure situation. Secondary growth failure is when there is a definable factor. It may be a nutrient defect, it may be an organ system dysfunction, it may be a hormonal deficiency or an excess state, and other things like psychosexual factors. So then it's a secondary growth failure. So when you have a child who doesn't have SGA, who is proportionate, who doesn't have syndromic or dysmorphic features, no macrocephaly, there are no secondary things, and there are no the chromosomal disorders, the main chromosomal disorders you have ruled out, then you call it as idiopathic short stature, and it can be familiar or non-familiar. It's important to be aware of all the pathways or the main pathways involved in short stature. And it's now very clear that the growth hormone axis is just one small segment of the defects of seen in short stature. And this is something which has come up in a big way. It's a MAP kinase pathway. So as you can see here, the MAP kinase pathway inhibits chondrocyte proliferation. So it's a kind of a negative regulator of growth. And activating this MAP kinase pathway is the FGF signaling pathway. There is another pathway parallel to the FGF signaling pathway, which is a C natriuretic peptide and its receptor related pathway, which actually inhibits this pathway. So obviously, the negative effect on chondrocyte proliferation is kind of removed by this pathway. And then there are these intracellular genetic factors like shocks, which acts in a positive manner by increasing chondrocyte proliferation directly or indirectly through other factors like various SOXs. And we have to be mindful of RASopathies also. RASopathies are those defects due to defects of RAS and post-RAS MAP kinase pathway defects, and typical one would be Noonan syndrome. There are various other things. This is something worth keeping in mind when you see children with short stature. Growth hormone defects and resistance pathways are kind of well elucidated. And there are some recent or some entities which were discovered in the last 15 years are basically products of the 21st century research, which are given at the bottom part, including the ALS deficiency, the acid labile unit subunit defects, which have mild growth failure, the pregnancy associated plasma protein defects, which is involved in cleavage of the IGF BP3 and IGF BP2. And as a result, when you have a defect in this pathway, we have very high levels of IGF-1 and IGF BP3. IGF-2 defects have also been defined in 21st century, IGF-1 receptor defects. So all of them present with, so when you have a late pathway, they usually present with microcephaly and pre and postnatal growth failure. In a growth hormone deficiency, it's usually just postnatal growth failure. So the basic evaluation of short stature, diagnostic workup in an asymptomatic child is something which I need not elaborate. All of you are aware of the basic steps, which includes a karyotype and growth marker evaluation. And then if everything is negative and if the oxology is suggestive of a growth hormone axis problem, then you go for a growth hormone stimulation test. And that would be guided by a delay in bone age as well. We are all aware of the various growth hormone provocative testing methods which are used. And the main ones used in India are clonidine and glucagon. Priming is recommended around 10 to 11 years of age with either testosterone or estradiol preparations. And with the newer growth assays, the cutoff of growth hormone used to define growth hormone deficiency has come down substantially. Nowadays, we think of growth hormone deficiency only if the growth hormone peak level is less than 7. Even that is just suggestive. And if it is less than 5, it's highly suggestive. And if it is less than 3, it's kind of, we are almost sure. So that's the kind of change which has happened in the last 10 years. And how about idiopathic short stature? So as I alluded to earlier, when the child is short, you don't have any secondary causes. The child is proportionate. The child doesn't have any chromosomal anomalies. Child doesn't have SGA. So basically, you don't know what is happening. So then you call it as idiopathic short stature. And it's important to realize that bone age delay can be a part of idiopathic short stature. So it's kind of important to understand the evolution of idiopathic short stature. So basically, it's probably a pharma-driven venture which started in the mid-80s. So basically, it's about using growth hormone in non-GHD short stature, and that was defined as idiopathic short stature. And later on, it was achieved as a diagnostic category. So now, with the opening of the genetic techniques and all the advancements, we know that there are a number of important genetic changes which may be responsible for idiopathic short stature. But it's also important to realize that only a small segment of patients we actually have identifiable genetic reason for short stature. So it's seen in less than 10% of patients. As I alluded to earlier, it can be familial. So familial short stature can also be part of idiopathic short stature, or it can be non-familial. So this is a big study from, or it's just an audit from Finland, just to give you an idea about how all the various causes measure up to each other. And there are these different quartiles. So quartile 1 is less severe short stature, and these quartile 4 would be very severe short stature. So to shorten the discussion, you can notice that the growth hormone deficiency just contributes a minuscule portion of the spectrum. And if you have lesser degrees of short stature, you have idiopathic short stature coming up in a big way. And if you are greater degree of short stature, the percentage of syndromic diagnosis increases dramatically. And in the last 10 years, evaluation of the idiopathic short stature genes have indicated that there are these 4 genes which are very important, and it makes sense to check for these genetic defects in patients with idiopathic short stature. And these are SHOX, aggregan, which is a protein found in the cartilage. NPR is a natriuretic peptide receptor, and FGFR3. So all these pathways, how they are involved in growth, we have already discussed. And previously, these pathways and these molecules were associated with very severe defects. For example, FGFR3. So that would be associated with achondroplasia and various other skeletal dysplasias. But now we know that minor defects of these genes can result in true idiopathic short stature. They don't have any disproportionate short stature. They just look like normal, almost normal kids who are just short. There is no mesomelia, nothing like that, which is seen in the extreme defects. So that is well described as part of idiopathic short stature. And then there are these non-classical growth hormone abnormalities which are thrown up as a result of the genetic analysis. So heterozygous defects of growth hormone receptor, intronic variants, and even post-receptor pathway variants, all of them heterozygous, they can also present as idiopathic short stature. I'll just end the discussion on genetics by just focusing on the new ACMG guidelines on how to go about genetic analysis of short stature. I just want to focus you on the middle part. When you have an idiopathic short stature and an unrecognized syndrome, basically, you start off with a SHOX analysis, which is usually you start off with a chromosomal microarray analysis or an SNP analysis. And then if it is normal, this analysis is normal, then only you go for a genetics or an exome sequencing. So most people have the tendency to order an exome sequencing first, and then, if you don't find anything, most often you don't find anything, and then you are lost. So why so? Why are we more interested in copy number variant or CNV analysis first? It is a result of number of studies which have shown that the pickup rate from SNP or the microarray or all this CNV analysis is to the tune of 10 to 16%. So it makes sense to go and do these tests first before ordering an exome analysis. So just summing up slide on when to go for genetic testing, which we have already talked about it now. Dysmorphic child, disproportionate, and short stature, positive family history, SGA. These are some of the indications why you would want to go for a genetic test. So this is what we discussed. We can go for specific analysis or an exome or a CNV based analysis. Coming on to growth hormone therapy, the game is all about using it in the right patient with the right dose, monitoring for side effects, and knowing when to stop growth hormone. And the latest guidelines have come up in 2016. This is from the Pediatric Endocrine Society again. One of the first things which I like most is about recommending against provocative test as a sole criterion for GHD diagnosis. So if you don't have clear oxological or borderline oxological criteria, you don't want to do a growth hormone provocative test, because so many of the normal children may not actually have that recommended cutoff. So the specificity of this growth hormone testing is not that great. The growth hormone assay should be standardized. Priming is recommended. And provocative tests are not recommended, or there is no need for a provocative test if the doxological criteria is met, there is a clear hypothalamic pituitary defect, and there is another demonstrable pituitary defect. Growth hormone deficiency diagnosis in the first month of life, something which have been asked during the endocrine exams, but now we know that all the cutoffs, old cutoffs are gone away now. So the diagnosis is possible biochemically only in the first week when the levels are less than 5 microgram per deciliter of growth hormone. There is a hypoglycemic episode and at least one pituitary hormone defects. So otherwise, it will be a bit difficult to diagnose based on random levels. Treatment part, there are a number of important aspects which have been discussed. And one of the things is about use in patients who already had a tumor. So it would be a malignant tumor or something else, a non-tumorous condition like a craniopharyngioma. 12 months waiting period is what is recommended. Weight-based dosing is recommended. 22 to 35, severe deficiency may respond to very small doses. IGF measurement is recommended according to society, probably because it's not something which we routinely do. We do it only in the patient does not respond nicely. Obviously, probably because growth hormone is provided for by the government and there are problems with adherence, IGF measurement has been recommended by the society. Routine incremental doses in pubertal doses as high as 100 microgram per deciliter, which is approved by FDA, is not recommended by the society. One of the important things they have emphasized is the need to reassess cortisol and thyroid axis defects during treatment. So you may start off by starting on growth hormone and you have ruled out thyroid axis defects, cortisol by doing appropriate tests. But once you start the growth hormone, things might change. And this point has been emphasized. You might need to retest the patient later on after starting during the treatment if the clinical scenario dictates a need for that. The discontinuation of growth hormone, everyone knows, and the reevaluation, something known to all of us, uncertainty about the long-term risk in patients at increased risk of tumors. It's some important point which I thought should be emphasized. Should not start growth hormone if there is a suspicion of chromosomal breakage and things like that, blooms, downs, Fanconi's. Noonan is the only thing in this group which is recommended, growth hormone therapy is recommended. Again, there is some uncertainty about the increased risk of tumors as per 2016 guidelines. And I'd like this opportunity to discuss something which is often misquoted, the association between growth hormone and tumors and the risk, the use in childhood and the risk in later on life of CV risk, cerebral hemorrhage. So the bomb was dropped in the early part of the 21st century by the French group. And they came up with this conclusion that there is increased risk of cerebral hemorrhage and a variety of tumors. And the question has been reasonably well answered in the last 2 years. And this is a publication from Lancet Endocrinology. And this is about the safety and appropriateness of growth hormone treatment in Europe study. And this involves not just France, but many other countries in Europe, involves close to 25,000 patients. And what the conclusion is very clear. The all-cause mortality was associated with the underlying diagnosis rather than growth hormone use. It makes sense that stratified the patient into various risk groups. Risk group 1, low risk, growth hormone deficiency, idiopathic short stature, skeletal dysplasia, etc. Notice that the risk increases when you come down. 1B is for SGA. You know, a lot of metabolic complications are described for SGA. And all these syndromes, there is increased risk and shortened life expectancy. So it seems they are actually responsible for the mortality risk and the tumors which are seen in some of the earlier studies and in the French cohort. Idiopathic short stature, the doses are 34 to 67 micrograms per kg per day. And a satisfactory response is something which is very difficult to define. And there is a suggestion to define it as a 0.3 to 0.5 height standard deviation increase over 1 year. Then if you don't get it, then there may not be a point in continuing growth hormone and wasting the patient's money, especially in the Indian setting. And so the reassessment of at 12 months is paramount. Two examples of the situations we are talking about this. The first kid has multiple pituitary hormone deficiency. And the second kid, it's not exactly idiopathic short. This is a Lerivale dyschondrosis. You can see the Madelang and all those stuff. And the doses recommended, you can see. And you can see the growth responses in this situation. Idiopathic short stature and growth hormone deficiency. Growth hormone deficiency, they pick up fast, they fly, and almost reach normal stature. Whereas idiopathic short stature, the response is very minimal in most patients. Of course, long-term therapy benefits are supposed to be around, if you use it for 5 to 6 years, it's supposed to be around 5 centimeters. Delaying puberty with GnRH agonists. This is something which has not been very favored in idiopathic short stature, although sometimes we do it. The most favorable effect has been seen in patients with SGA, not in patients with idiopathic short stature. Other things have already been discussed by Dr. Sriram. Use of oxandrolone in Turners. Aromatase inhibitors have been tried in boys, and this is something, there are a number of publications which suggest benefit. But personally, we don't have a lot of experience with the use of aromatase inhibitors because very difficult to sort of explain it in the Indian settings and institute treatment. So there are some benefits with use of aromatase inhibitors in males. So in a nutshell, I come to the last slide. We are talking about idiopathic short stature, which is not a single entity, but a diagnostic and therapeutic basket. The genetics, we have a lot of exciting discoveries in genetics, and in the future days, we will have more genes coming up where etiological agents for idiopathic short stature. We also discussed new guidelines for the judicious use of growth hormone in growth hormone deficiency and idiopathic short stature. With that, I end my presentation. Thank you all for the patient hearing, and over to the sponsors for further proceedings. Thank you very much.
Sir, there are questions in the chat box.
Sir, thank you, Praveen, sir. So, Velu, will you be able to read out the questions for the...
Yes, sir. Yes, sir. Sir, first question, what are the criteria for starting GH in a children with a short stature, with steroid-resistant Cushing and low IGF-1 and GH stimulation and values? What is your experience of use of GH therapy in this group?
Yeah. So I think the steroid use and this thing. So I think it's not a usually recommended thing, but there are these expert guidelines for use in steroid this thing. So not during active therapy. So mostly it discusses patients who recovered from, it's after a surgery, child had Cushing's and the patient recovered. So same thing has been applied to patients who are on steroid therapy and just has been stopped recently. So you are supposed to monitor the patient for some time. And if the growth velocity is extremely poor in the first year, that is a relative indication to use a growth hormone. And not much of rigorous guidelines, at least I am not aware of it. And that is an expert recommendation. And I would invite Dr. Sriram Mahadevan's comments regarding this aspect.
fully agree. I have had an opportunity in steroid resistant nephrotic and those. These are all indications where you won't have big guidelines. That's what I personally feel. Even if they are there, it will be anecdotal on few patients, and go by your clinical judgment and use with all your basic knowledge on this. I agree with Dr. Praveen that my experience is very minimal on these things. And these kind of patients, very often the primary condition itself is a pretty costly condition for them. And on the top of it, you say growth hormone, many times they run away. After counseling, I have not seen many patients returning. That's frankly the practical experience in our setup in some of these.
Thank you, sir. And second question, when to start on GH therapy in ISS?
Yeah, I think we had some 2-3 slides on this aspect. So the standard guidelines of minus 2.25 and all those stuff. So we can be relaxed to -2. So, I had a slide on this. So it's going to be, it's a very simple thing. When you are seeing, you have monitored the child over some time. It's not that you just decide out on the first day. You're seeing the child first time. You keep the child under follow-up, monitor for 6 months, and you see that the growth is dismal. And the predicted height, of course, there are limitations in our prediction, but you know that it's not going to be very dismal. Then you are desperate, and that is when and of course, there are finances. And that is when you go around starting a growth hormone. And when I start, I usually tell them that, the response may not be that great. We will have to reassess at least the 6 monthly intervals. And at the end of one, we will take a call on whether to continue it. 1 year, if the response is very bad, then, no point in continuing it. And we have these guidelines about, this 0.5 to 0.3 to 0.5 is DS, rise and all those stuff. These are rough guidelines, again, not supported by everyone, but makes sense.
The next question, sir. May I know the age of youngest children started on GH in TS by panel?
So I think the person is asking for our experience on the youngest child. As I think during my talk also I mentioned, maybe Praveen, I was lucky to a mother, very skeptical about the child's growth as early. So my only one child I have started at the age of 6 or 6.5. Almost all other Turner syndrome, I was never lucky to diagnose it at that early. This is my personal small experience. Maybe Praveen will have much higher follow-up.
Yeah, I think it depends on where you practice. So we have, we are fortunate to have the service of a clinical genetist. So obviously all these prenatal things and all those stuff. So, as Dr. Sriram rightly pointed out, when they come to us, it's usually late. But the genetics guys may pick it up earlier because of the prenatal stuff and all other things. So we have patients on growth hormone right from the age of around 3.5 to 4 years. That's a kind of almost a toddler sort of situation. So, but that's not the usual case. Usually it is much delayed.
Thank you, sir. The next question. Hi, doctor. What's the appropriate dose for Turner syndrome to get best medical outcome?
I presume this doctor is asking on the growth aspect. So I think we discussed during our presentation that the dose is much higher than the usual growth hormone deficiency, and it will be anywhere from 40 to 50 microgram per kg per day to start with. And you have to titrate it over the next 3 months, 6 months and see how is the response. As I said, this is one indication where IGF-1 monitoring is also important. And I mean, you can use a slightly higher dose. You can go up to even 70 rarely, and optimize based on the oxological response, and monitor for metabolic side effects also, and any other side effects which we discussed. So that's how we go about usually. Praveen, you want to add it?
No, I think that is the right thing. And of course, as Dr. Sriram had pointed out, this scoliosis and all those stuff. And when you use these high doses, then you are likely to get into trouble. Personal note, I have never been able to cross 45 to 50 micrograms. By that time, the IGF usually reaches around 3 standard deviation sort of values. Then you're forced to back down. And I am a bit skeptical about the higher doses. We might land up in problems also.
Thank you, sir. The last question, sir. Post 10 years of approval of idiopathic short stature as an indication, what's your experience on ISS with GH therapy, efficacy and safety also?
Yeah, I think we have discussed this already. Obviously, it's not 10 years, it's more than that. But so basically, the response, the study wise also, you'll be very lucky to have a patient who responds very nicely. So most of the patients, the response are rather modest. So it's kind of, when we talk about turners, we say that the yearly response is to the tune of, around 1.5 centimeter, or maximum, if you're very lucky, then 2 centimeter extra. But here we are talking about gains of 0.8 to 1 centimeter extra. So use it for 5 to 5.5 years, then you gain around 5 centimeters, that sort of situation. But then obviously, for desperate patients, it's worth a try. And as we discussed earlier, we are going to reassess at the end of 1 year and take a call on whether to continue. The safety aspect, the idiopathic short stature is one category in which, unless you have missed some sort of problems like scoliosis, we don't run into too much trouble with intracranial hypertension and all those. The three chief things are intracranial hypertension, the slip capital epiphysis, and this thing, scoliosis worsening. So the rest are mostly theoretical aspects. So if you carefully look and rule out scoliosis, we don't come across much problems in idiopathic short stature. But of course, we don't go for a very high doses in the first go. We start with a modest doses and slowly build it up. Mr. Srinivas, are we done with the questions?
Yeah, I think so.
Yeah.
It's too late.
Yes.
I'm surprised from Kerala. Praveen is still awake and in part of a meeting.
Really,
I'm told in Kerala you finish very early, no? Before 7:30.
Oh, that was probably a few years back. Now things have changed.
good to know, sir.
Nice online.
Sir, extremely thankful to both Sriram sir and Praveen sir. So wonderful. Literally we enjoyed, sir. I'll not take much time. Only two things I want to bring it to your notice, sir. One is, Pfizer as a company, 99.9% of the times promote growth hormone to qualified endocrinologists and pediatric endocrinologists only, genotropin, and the coming long-acting growth hormone also. So that way, rest assured, only the approved indications only will be promoted. That is one thing I want to bring it to the notice of the HCPs who is attending this meeting. Second is, sir, in both of your states, very fortunate, all the southern states, in fact, now the central government has taken an initiative to have the Center of Excellence for the rare diseases, where some indications like Prader-Willi syndrome, when the patients are not affordable, in case of Tamil Nadu, it is Institute of Child Health, and in case of Kerala, it is the SAT, the Trivandrum are having the center of excellence where those unaffordable children also can get the advantage of growth hormone therapy. So provided a qualified endocrinologist endorse a kid to use genotropin or any growth hormone, so that is available through Ayushman Bharat and the Center of Excellence. So I thought it would be really useful information for the HCPs to refer those eligible required patients to the qualified endocrinologists. So, sir, I don't have words to express my gratitude to both of you at this hour also, being really, core to the academic and helping the HCPs to bask in the wisdom, on short stature and growth related disorders. Gratitude, Sriram sir, Praveen sir, and all the HCPs who attended this program. Pfizer will continue its thrust on academics, and we will try to engage as much as possible with the academics. So good night one and all, gratitude to one and all. Thank you sir.
Thank you very much.
Thank you.